I'm Rosie Forster. I'm a principal EQA scientist here at Birmingham Quality, and I lead on our point of care testing EQA schemes. So I'm going to talk a bit about our experiences in running point of care testing EQA schemes in clinical chemistry today. So if you are not already aware, within the UK NEQAS Clinical Chemistry Division, we run a number of point of care testing EQA schemes. The analytes that we run them for include HbA1c, lipids, creatinine, and urine dipsticks here from here at Birmingham Quality. Cardiac Markers Centre in Glasgow runs EQA schemes for troponin and NT-proBNP. And Edinburgh Peptide Hormones run EQA schemes for urine pregnancy testing and preeclampsia markers. Some of the methods for measuring the preeclampsia markers are point of care analyzers. But I'm going to mainly focus on the schemes that we run from Birmingham Quality today. So when it comes to running a point of care testing EQA scheme, this is a very different cohort of participants to the laboratory. We provide a much simplified report format where participants are able to see their result against the target and they get a tick or a cross based on whether their result has been within the acceptable performance limits. Basically, as it says on the slide, you don't need to be a statistician to interpret these reports. Many of you may have seen our laboratory EQA reports that give lots of information on the different methods used by participants in the scheme and lots of different data to help you to troubleshoot your EQA performance. We don't provide that much data on the point of care testing EQA reports because it would confuse a lot of the participants. So we try and keep it as simple as possible. Information that might be included on the report are things like who performed the analysis and the lot number of reagent strips. Now, this information isn't especially useful to us, but we recognise that it is probably going to be quite useful to the participant if they are trying to troubleshoot poor performance. So if you know who performed the analysis, you can talk to that person about whether there's a training issue in terms of performing the EQA analysis. If you know the lot number of the reagent strips, you can check if they were still in date at the time or whether if the device doesn't have a lockout that stops you from using out-of-date cartridges, has that been overwritten in the device, just as an example. And things that the point of care testing participants can do to investigate their poor performance, things like often we see no return for the EQA. So we need participants to sort of understand why that's happened. So are they still using the device or is there something wrong with it? Was there a training issue for the operator of the device? Were they trained and competent? We'd need them to consider how the specimens have been handled prior to analysis, whether there was a delay or whether they could have accidentally been frozen. In the community, this is unlikely, but it is something that can happen with whole blood EQA in laboratories. And one point that we often reiterate to our participants is that although we can assist with troubleshooting, we weren't there on the day that the analysis was performed. So we don't know exactly what happened. Our participants are in the best place to know exactly what happened on that day and what went wrong. Often it's likely that the reason for poor performance in our point of care EQA schemes is that there's been a delay in analysis or the specimens, which are freshly prepared whole blood, have not been adequately mixed prior to analysis. We provide user guides for our participants for how to analyze their EQA samples and how to submit results. So we do this for some specific devices that we have participants using within our schemes. An example here is for the CardioCheck device, which is used to measure lipids. So we also, for some of our schemes, we do send out information about troubleshooting. So this is one particular scheme that we have where when we review the results when a distribution closes for submission, we also have a look at which participants are out of consensus and which haven't returned results. And we will send an email out when the report is published asking those participants that have unsatisfactory results to check their report, and also to give them some instructions for what they can do if their results are not satisfactory. So we do provide quite a lot of support for our point of care testing EQA participants. And it's a different cohort to the laboratory in a lot of cases. So one example of a point of care EQA scheme that we run is the UK NEQAS for urine dipstick scheme. So urine dipsticks, if you don't already know, are basically test strips that have multiple parameters on them that are dipped into a urine sample, and then they can be read either against a coloured interpretation chart or on an automated reader. The results of a urine dipstick analysis can tell you quite a bit about general health, but the main reason for performing a urine dipstick is either to detect glucose in the urine that might be present in a diabetic patient, or to detect nitrates and leukocytes that might be present in a patient with a urinary tract infection. So for this scheme, what we have set up at the results submission to make things as simple as possible for the participant is a replication of the interpretation chart for their urine dipstick. So they can click the radio buttons and submit their results based on what they have actually seen on the dipstick chart and how it matches to the coloured pad. We then put a similar display on the reports where the colours do match what the participant should have seen, and we tell them what the consensus result was between all participants using that manufacturer's dipstick, because the dipsticks are quite different between manufacturers. And this is we think, a pretty good visual representation of EQA performance for that participant. We also list all of the parameters and we give them an indication of the trend in their performance. So has it generally been good? Has it recently deteriorated, or has it been quite consistent? And there we show them the coloured pads for a few different manufacturers, and they can see how many participants are using each manufacturer's dipsticks. And this is just a zoomed in version of what the participants see with the coloured pads. We can also see that there's a column there with a response. So on top of the pads on the interpretation chart, there will be a corresponding number, which might be a concentration, or it might be a value such as a 1+ or a 2+, or normal, negative or positive. And we also do include this on the report. But if a participant is actually using an automated reader rather than interpreting the dipsticks by eye, they might get that output from the reader. And here, again, we can see that the on-screen colours on the report match the pads on the dipstick interpretation chart, and we can display pie charts showing the proportion of participants who submitted each response. So we can see here that this particular specimen, the consensus was that the pH was 7.5. And for glucose, the consensus was that the specimen was negative, but a handful of participants did detect some glucose in it. So I've mentioned dipstick readers. At the moment, we don't designate which participants are using the dipstick readers within our scheme, but from January 2026, we will be introducing dipstick readers as a method option in the UK NEQAS for urine dipstick scheme. We will be sending out a link to all of the participants with a Microsoft form for you to fill out to confirm which reader you're using, if you are using one, and your methods will be updated online by us. So watch this space because that is coming soon. We also are aware that for point of care, there may be a lot of devices overseen by a hub coordinator. So we tend to use a hub and spoke model. And this is just an example of a hub coordinator's report, where the hub coordinator can see how many registered participants they have in their hub, what the return rate was, and this is a really good one, it was 95%, but they can also see how many devices within their hub were within the acceptable performance limits and how many failed for the analytes in question. And again, we give them an overview of all of the spokes or devices within their hub and how those devices have been performing. So we've got here data from the current distribution at the specimen level, which shows how each device performed for that specimen for each analyte. and the data from the recent performance, which is the last few distributions. And that gives if you can see the arrows in each circle for each device, give an idea of the trend in performance. Most of these ones look really good. We've got a sea of green, which is what we want to see. So in clinical chemistry, most point of care testing is overseen by a laboratory point of care team. And this is good because laboratories understand EQA, they understand why it's necessary to do it from a quality assessment perspective. However, point of care is often most beneficial outside of the lab in settings where a rapid clinical decision is required. Results do need to be comparable to the lab if the patient is also having samples sent to the lab. We find that in clinical chemistry, and I imagine this is the same across all disciplines, that staffing levels of laboratory point of care teams, which are often multidisciplinary, vary from a large team that works across a whole network to a single member of staff who manages the point of care testing devices alongside the routine laboratory workload, and they don't get a full-time role doing that. But we also find that there is point of care testing being carried out in the community, which may not have any oversight from a laboratory at all. And in these cases, the difficult part is getting buy-in from end users about why doing the EQA is important. There is national guidance for point of care testing. So there is this document published by the ALM, the IBM, the Association for Laboratory Medicine, the IBMS and the Royal College of Pathologists, which gives guidance for what should happen when point of care testing is being offered. And this is quite specific in the requirements for quality assessment of devices. There is a point, and it's mentioned a few times in the document, that devices need to be subject to appropriate internal quality control procedures and registered for EQA, and performance should be monitored by a laboratory healthcare scientist. So that's going to be quite important when we come on to talking about specific EQA programs. So the first specific EQA program that I want to talk about is HbA1c and lipids as part of the NHS Health Checks program. So the NHS Health Checks program is targeted at people aged 40 to 74 years and at increased risk of type 2 diabetes or cardiovascular disease. So to assess diabetes risk, HbA1c or glycated hemoglobin A1c may be measured. And the range 43 to 47 millimoles per litre would suggest pre-diabetes. Greater than or equal to 48 millimoles per mole is suggestive of diabetes. The lipid profile, including total cholesterol, HDL cholesterol, and the total cholesterol to HDL ratio, is used to assess cardiovascular disease risk, and the Q-RISK-2 tool, and there is now a Q-RISK-3, uses the total cholesterol to HDL ratio alongside a number of questions about lifestyle-related factors and age to calculate a risk of developing cardiovascular disease in the near future. The programme was launched in April 2009, and initially this utilised laboratory testing and samples were taken from patients and sent to their local lab. And this programme is delivered in general practice, and it's often commissioned by local authorities. So there was this review published in the BMJ about how use of point of care testing could improve cost effectiveness of the NHS Health Check programme. And the thought here was that the use of a point of care device to do the health checks tests facilitates communication of the cardiovascular disease and diabetes risk scores to patients in a single visit. So if samples sent to the lab, the patient has their blood test appointment, the sample sent to the lab, they have to wait for the result to come back, and then they would need to come back for a follow-up appointment to discuss the results. But if you can do a point of care test while you have the patient there, the patient doesn't require a second appointment to discuss their results because they've got them in that first appointment. So therefore, they're less likely to DNA a follow-up appointment. So actually, this could potentially be less costly to the NHS overall because less staff time is wasted in patients not turning up. And it's a lot more convenient to the patient too. but point of care testing is actually more expensive than laboratory testing, so it's a fine balance to maintain. Here are an example of some of the devices used in the NHS Health Checks programme. We've got at the top left the Roche Cobas B101, which measures both HbA1c and lipids. We have the Lumira DX, which measures HbA1c. In the top right, we've got the Abbott Affinion 2, which also measures HbA1c and lipids, and they're quite good sort of little benchtop analyzers, essentially. We've got the handheld CardioCheck device, which is just used to measure lipids, but has a variety of different strips available, including some with glucose. And the Quotest HbA1c analyzer, which goes alongside the CardioCheck. In many cases, they're distributed by the same company. So doing a point of care test for the health checks sounds great and obviously could have a lot of benefits. So what is the problem here? Well, the commissioning power for NHS health checks is given to the local councils, and they rarely involve labs in the health checks programmes. A problem with point of care testing is that devices are not seen as laboratory tests because you can just buy a device and start using it. And this is an issue in lab point of care testing, as laboratory overseen point of care testing as well, because often the first that a point of care team will hear about a device is when the clinician that's bought it starts to experience problems with it and they don't know what to do, so they contact the laboratory point of care team. So when the health checks are commissioned by the local councils, there's often not much thought, if any at all, given to quality and governance. I had a phone call with one such organisation who was trying to commission their local health check service. And while I was discussing our EQA programs with them, this person actually said to me, someone told me I don't need to do this. It's like, well, no, you don't need to, but the guidance does strongly recommend that you do. There's no legal requirement, but if you don't do it, how do you know that your device is performing as it should be? We're often approached by the local authorities to provide EQA services for their health checks devices, but there isn't much understanding of why this is important, and it's obvious that they are just trying to tick a box. And EQA is not just a box ticking exercise. This is a very different participant base to the hospital-based point of care testing overseen by lab point of care teams. Problems with the community-based point of care testing include that often there is a really high turnover of staff. So someone may have been trained to do the health checks tests and then they leave, and suddenly there isn't anybody who is trained and competent to do that test. There are also some private health check services set up in non-healthcare settings like gyms and health clubs where people will actually pay to have the health check done. And we do find that for most of our point of care testing EQA schemes, no matter what we do, the return rates for EQA are very poor, even when we send them at a much lower frequency than we would for laboratory schemes, such as every other month. Often in the community, cost is the most important consideration when choosing an EQA programme. Participants aren't really bothered about the scientific elements, but they just want what we would call the green fluffy tick. The other problem is that patient results are usually obtained from a finger prick sample that's been directly applied to the test cartridge or strip from the patient's finger. When the participants receive their EQA, the sample tube has to be handled a bit differently because they can't just pour it onto the test strip or cartridge. But we do provide instructions and training material on how to handle the specimens. We provide them with a little tray, little weighing boat, and pastettes or pipette tips that they can pour the sample onto and then use that to apply it to the test cartridge, but the instructions are not always followed. We give them a much simplified report format, as we've already been through, which shows quite clearly whether or not the device has performed as it should have done for that distribution, and how the device has been performing for the last few distributions. And some genuine queries that we've received from point of care testing participants in the community have included things like, I've received my calibration samples from you and the results passed, so the device is okay now for a year, isn't it? It's calibrated. there's a lack of understanding about what the EQA samples are actually for, and it's assumed that they're calibrators, essentially. Another common message that we get is, sorry, we didn't analyse the samples because it's usually done by this one person who is on holiday or off sick this week. Another one we got was that the samples were received by a participant and they were at room temperature for 2 hours, and the participant decided that they weren't suitable and threw them in the bin. So although we advise that samples need to be refrigerated if the participant can't analyse them straight away, 2 hours is not a long time for them to have been at room temperature. We're talking more than 24 hours. Often we get a message saying that all the test strips have expired, so the participant wasn't able to submit a result, and I hope they're not using them for the patients. We dispatch, because we're dispatching a large number of samples, we have a schedule for dispatch. And we usually dispatch our point of care programs on a Wednesday, but participants have asked, can we post their samples out on a different day? Because the person who will usually do the health checks analysis isn't in on a Thursday to do the EQA. One comment that we got was that participants thought it was some sort of animal blood that we were sending them. It isn't, it is human, but they weren't sure how to dispose of it. We've had participants enter a 0 if they were unable to analyse the samples or get a result, which isn't okay because a 0 is still a numerical result and it can affect the data analysis. And another common one is that the participants often lose their username and password, or they don't. One person takes responsibility, and when they leave or are not in, they don't pass those on to other staff members. And we've had paperwork sent to us in the post with results written on it before. So another sort of analytical point for the NHS health checks is that the devices may not actually be that good. We have a review here from the BMJ about the evidence for point of care tests for cholesterol. And this reviewed 6 point of care devices for analysis of lipids and the evidence base for their clinical utility. And it was found that the evidence base was actually quite poor, and the studies about this varied in quality quite greatly. And only 2 of the 6 devices were actually found to be fit for purpose following a systematic review of the literature. And the total cholesterol results varied greatly on most of the devices, which is something that we do see within our EQA schemes. And this is just an illustration of that. This is 2 devices that are used to measure point of care cholesterol. This was the same specimen measured on both devices, and the targets are the method mean, and they're quite similar, but the range of results submitted was greater for the first device, ranged from 3.4 to 6.2. For the second device, it ranged from 4.2 to 5.4. So the quality of devices does vary greatly, and the general cutoff used for where cholesterol is considered to be high is around 5. So that's a concern. And we are finding now that some health checks commissioners are choosing to return to using laboratory testing over point of care testing, which appears to be largely due to cost. So the financial saving that was anticipated with the increased use of point of care testing might not have materialised. So just wanted to cover a little bit more on HbA1c, which we've already mentioned, is used to assess risk of developing type 2 diabetes. But it can also be used in the assessment of type 1 diabetes. Again, I'm sure everyone knows what diabetes mellitus is, but it's a metabolic disorder that either comes with a defect in insulin secretion or action, leading to hyperglycemia. So type 1 is the failure of the pancreas to produce insulin, which often has an autoimmune cause. And type 2 is the resistance of the tissue to the action of insulin, which is often lifestyle related. Diabetes is a major health problem worldwide due to the consequences that it has for the cardiovascular system, the nervous system, the eyes and the kidneys. And around 90% of cases are type 2, which predominantly present in middle age. In 2011, the World Health Organization advocated the use of HbA1c for the diagnosis and monitoring of type 2 diabetes. So HbA1c is a glucose residue attached to the N-terminal valine of the beta chain of hemoglobin. If you haven't understood what that is, basically the higher your general circulating blood glucose, the more glucose you will have attached to your hemoglobin A1C. And then this can be used as a surrogate marker for how well you've kept your blood glucose under control over the lifespan of a red blood cell, which is about 120 days or 3 months. Again, we've got the World Health Organization guidelines for classing someone as pre-diabetic or diabetic. And there are some potential benefits of measuring HbA1c by point of care testing. The assessment for diabetes usually involves at least 2 GP appointments and a wait for a laboratory result for HbA1c, so diagnosis can take some time. And then HbA1c is monitored every 3 to 6 months after diagnosis. So again, that could save time in terms of patient appointments and follow-up. And point of care testing would allow provision of immediate results, resulting in earlier diagnosis and fewer appointments. And the screening for diabetes occurs as part of the NHS Health Checks programme. But how good are these devices really? This was not a point of care testing device, but those of you who work in clinical chemistry will be aware of the recent incident with diabetes test results and HbA1c test results in laboratories, which have left 55,000 patients being recalled for a repeat HbA1c due to analytical problems. And this number is actually estimated to be higher, but if you do get the testing wrong, it could have big consequences. So in terms of measurement of HbA1c, it's really important to check in the literature for your point of care device if the device is suitable for the diagnosis of diabetes or just for the monitoring of HbA1c concentrations. So the next analyte that I'm going to cover is creatinine. So creatinine is a waste product of the breakdown of creatine in muscle tissue, and it's produced at a relatively constant rate, filtered out of the blood by the kidneys. So by measuring it in the serum, we get a good idea of how the kidneys are functioning. Circulating creatinine levels are also impacted by sex, size, age, and muscle mass of an individual. Serum creatinine concentration, along with the age and sex, are used to calculate the estimated glomerular filtration rate, or the eGFR. The eGFR is an indicator of how effectively the kidneys are filtering, rather than functioning, small molecules like creatinine out of the blood. And the eGFR is used to screen and monitor for kidney damage. So if your creatinine concentration is higher, you have a lower eGFR because your kidneys are filtering less effectively. And the creatinine concentration is also used in algorithms to detect acute kidney injury, or AKI, which is a rapid deterioration in kidney function. In the laboratory, these don't usually use the eGFR to look at the AKI risk. There is a NICE guideline for point of care testing of creatinine to assess kidney function before CT imaging with intravenous contrast. So giving intravenous contrast to a patient can cause AKI if their renal function is already compromised. A NICE guideline DG37 recommends using 3 devices: the ABL 800 Flex, which is a blood gas analyzer, and the iStat Alinity and Stat Sensor, which are 2 handheld devices, to calculate the eGFR to assess kidney function in order to guide decisions on whether to use IV contrast during an outpatient CT scan in adults. The recommendation is that they should only be used when there isn't a recent laboratory eGFR result available, and if a person has risk factors for AKI, and if clear governance structures for point of care testing are in place. The devices do calculate eGFR, as we've said, so the age, sex, and ethnicity could be taken into account when assessing the risk of AKI, and the age and sex would also be used to calculate the eGFR on the device. Some of the devices do give a choice of equation used to calculate the eGFR as well. So we do at Birmingham Quality operate an EQA programme for point of care creatinine measurement in whole blood. So the point is to assess whether the patient is at risk of AKI. And the clinical decision that might be made is to give that patient more intravenous fluid to keep their kidneys, well, to keep them hydrated and to sort of keep their kidneys functioning to reduce the risk of AKI, or their scan might actually be cancelled if it's felt like the risk of giving contrast media is, the risk of AKI from giving contrast media is too high. And there is an encouragement in the guidelines to obtain a laboratory EGFR measurement if possible, and not to rely solely on point of care creatinine measurement. So the cutoff that NICE DG37 recommends for as the EGFR that would be considered to be low, and at which point the risk of AKI is possibly too high to give contrast media for a CT scan, is an EGFR of 30 millilitres per minute per 1.73 metres squared. And as we've already said, the guidelines state that point of care creatinine measurement is preferable. Laboratory creatinine measurement is preferable, and that point of care should only really be used when the patient has a risk factor of AKI, they don't have a recent laboratory result, and the cancelled CT scan appointment can't be offered to another patient. But again, we have a problem here with the devices. This was a whole blood specimen. The creatinine concentration in the pool was 100 micromoles per litre, and we measured this on an Abbott iStat device that we have in-house before it went out in the scheme. But that was what we were aiming for with the spike. We can see here that on the left, we've got the Abbott iStat and Alinity series, where the creatinine target was 97 micromoles per litre. So that's quite close to what we were aiming for. And we give all the participants patient demographics to use in the EGFR calculation, and we tell them to assume the patient is a 60-year-old white female. So based on that creatinine of 93 or 97 micromoles per litre for the iStat, the EGFR comes out as 58. On the Novastat sensor, which is a different device, the same sample, same EQA specimen, produced a target value of 163.9 micromoles per litre, which would give a calculated EGFR in a 60-year-old white female as 31, which is really close to the NICE recommended cutoff for not performing a CT scan. So it is a real concern to us that the devices produce such different results. And it isn't just our EQA scheme that has spotted this. This was a published review looking at different point of care testing systems for creatinine and evaluating their performance and clinical utility. We can see here when the EGFR calculated from the point of care device is plotted against the laboratory calculated EGFR, that there is a much greater variation in the Novastat sensor and the Abbott iStat. The colours on the graph refer to classification of chronic kidney disease. But again, this is a concern that obviously both of these devices are recommended for use for the same purpose, yet produce very different results. So essentially that's just what we've covered, that if patients do have a point of care creatinine device measured by the Novastat sensor device, their creatinine concentration is going to be higher, their EGFR is going to be lower, so their kidney function looks apparently worse. And therefore, they're more at risk of being misclassified as a potential risk for AKI if contrast media is given if the Novastat sensor is used. So that could potentially mean that some patients' CT scans are being cancelled unnecessarily where this device is being used. And we are aiming over the next year or so to undertake a lot more further work in this area. So coming back to point of care testing EQA, what is there that EQA providers can do about some of the challenges that we see? And really, we don't have any authority and there's only so much we can do. But what we would encourage laboratory point of care teams to do is try to find out what is happening in your community areas in terms of point of care testing, and whether there is anything that you didn't know about, particularly in sort of GP surgeries and pharmacies, and engage with the users to improve quality and governance. We also have some of the EQA devices that our participants use in-house, and we often use these to check that our material is suitable for it, which it is because it is human whole blood, and to assist participants with their troubleshooting. And this has been really useful because it's allowed us to replicate some of the problems that participants have seen. As an example, for one of the devices that we have in-house and that we have participants using, we received a lot of messages at result submission about a particular error code. And what we were able to find out was that the participants were actually running the EQA samples as though they were IQC material, and they were running them in a QC mode, which was causing errors on the device. So we were then able to reach out to the participants and provide them with further training material to try and stop this from happening. And we are also in the process of writing a point of care testing participant survey for our participants. And we'd like to find out especially from the community-based participants, what their understanding is of what EQA is and why they need to do it, how they choose their EQA provider, and what educational and training material they would find most helpful.